Welcome to Oncology Today, Bispecific Antibodies in the Management of Non-Hodgkin Lymphoma. This is medical oncologist Dr. Neil Love. For this program, I met with Dr. Jennifer Crombie from the Dana-Farber Cancer Institute in Boston. And to begin, I asked her to provide a general overview of the various approved and investigational bispecific antibodies for the treatment of non-Hodgkin lymphoma.
Bispecific antibodies are an exciting new class of drugs that are available now for patients with lymphoma. They're also being studied in other subtypes of hematologic malignancies and now making their way into the solid tumor space as well. But in lymphoma, the bispecific antibodies of interest bind CD20, which is a marker on the lymphoma cell, and CD3, which is on a T cell. And so by bringing the T cell into close proximity and with this dual binding, there can be activation of the T cell and T cell mediated killing of the lymphoma cell. And so we currently have 4 bispecific antibodies that are the furthest along, 3 which are approved in the US, and then a 4th which is approved in Europe and may get approval in the US soon. So I'll just kind of walk through each of them. I'll start with mosunetuzumab. This is a bispecific antibody that is FDA approved for follicular lymphoma in the United States, and it is an IV therapy. It's a time-limited therapy. Patients are treated for 6 months if they have a complete response, or up to a year if they don't achieve an early CR. And because of the risk of cytokine release syndrome, which is one of the key side effects, it's administered using a step-up dose. They actually all are. So that's mosunetuzumab. The next one to mention is epcoritamab. This is unique in that it is given subcutaneously. It's also the bispecific that currently has 2 indications. It's approved for both follicular lymphoma and diffuse large B-cell lymphoma. And all of these right now have their approvals in the relapsed refractory setting. Also uses step-up dosing, and unlike mosunetuzumab, epcoritamab is given in a continuous fashion, meaning that patients remain on therapy until they either have disease progression or an unacceptable toxicity. The next to mention is glofitamab, which is available for diffuse large B-cell lymphoma. This has a slightly different structure. There's 2-to-1 binding of CD20. So 2 sites bind to CD20 for the 1 CD3 binding site. And this drug, unlike the others, it's also standard to use obinutuzumab as a single dose prior to the initiation of the dose ramp up, and that's used to mitigate the risk of CRS. That is also a time-limited therapy for 12 cycles. And then the other drug to mention, which is available in Europe and awaiting approval in the US, is odronextamab, which has been studied in both follicular lymphoma and diffuse large B-cell lymphoma. This drug has a unique step-up dosing schema. There was early cytokine release syndrome seen, and so they have a modified step-up dosing plan where the dose is split over 2 days for each step-up dose, and this is given continuously in the same way that epcoritamab is. So they're all similar in that they bind CD20 and CD3, but they all have their unique details about each of them.
So, of course, cytokine release syndrome is, and as you mentioned, an important issue here. When you look at these 4 agents, obviously we have an indirect comparison, so that's a little bit of a challenge. But what do we know in terms of tolerability of these 4 bispecifics, and particularly intensity of cytokine release syndrome?
Yeah, so we first got used to seeing cytokine release syndrome in the context of CAR T-cell therapy, which became available first in large cell lymphoma and then follicular lymphoma. And there, the rates of cytokine release syndrome and the severity or grading of cytokine release syndrome are a little higher. So it is encouraging to see that the bispecific antibodies, while they do have the same phenomenon, seem to have less frequent cytokine release syndrome and less severe cytokine release syndrome than what we've seen with the CAR T cell therapy. But it is still an important side effect to be aware of, and one to kind of know what to do if it does occur. So we see cytokine release syndrome. It's hard to compare across the clinical trials, but it seems to be slightly different with the different drugs, and it's important to also take into account the disease. So for follicular lymphoma, slightly lower rates of cytokine release syndrome. And compared with the other drugs, mosunetuzumab does seem to have slightly lower rates of CRS. That drug has, for all the follicular lymphoma drugs, they've been able to give them in the outpatient setting because of these lower rates of CRS. The drugs are also, the dosing is a little bit different with each step-up dose, so the timing of CRS can also be different depending on the drug, and I'm happy to go into more detail about that. But with diffuse large B-cell lymphoma, the rates are a little higher. It's really hard to compare epcoritamab to glofitamab in terms of the frequency. We see it just at different times, but it's a similar frequency. Slightly over half of patients in clinical trials seem to have CRS, but predominantly grade 1, and then a small subset of patients having grade 2. It's pretty rare to see grade 3 or higher CRS with these drugs.
So what about efficacy? And maybe you can include odronextamab in this discussion, even though it's not currently approved, at least not yet in the United States. But when you compare the agents that have been studied, and we have good data on for follicular lymphoma, and also those that have been studied and are being looked at for diffuse large B-cell, indirectly, how would you compare efficacy?
Yeah, it's challenging to compare across the different studies, of course, but I think that for diffuse large B-cell lymphoma, where we have epcoritamab and glofitamab, the efficacy does seem similar. Both the response rates that we see in terms of overall response rates are around the 50 to 60% mark, and the same with odronextamab for diffuse large B-cell lymphoma as well. And then CR rates are somewhere around 30 to 40% across those drugs. And now we're seeing for the two approved drugs we saw this year at ASH, 3-year follow-up data from the initial phase 2 clinical trial. So we're starting to see longer follow-up. And what has become clear in those studies is that among patients, if you are able to achieve a CR, patients can have prolonged responses, and they did seem pretty similar across the different drugs. Odronextamab, the study design was a little bit different. Their phase 2, they had a cohort of DLBCL patients that didn't have prior CAR T, and then they, in their phase 1, they had a specific expansion cohort of the ELM-1 study that was all patients who had failed prior CAR T. And that was a really high-risk patient cohort, about 60 patients, and many of the patients had recently had CAR T within 90 days, about half of patients, and response rates were pretty similar, even in that post-CAR T cell cohort, with response rates almost at 50% for that high-risk group. So I think it's hard to compare, but they all seem pretty similar. And then the same for follicular lymphoma. We have the mosunetuzumab and epcoritamab and odronextamab, which have all been studied, and responses there are a little bit higher. Overall response rates more in the 80% range, and CR rates in the 60% range. And we have now published for mosunetuzumab 3-year follow-up, which is showing the same trend among those patients who have achieved a complete response. The duration of response is quite long, around 3 years, median PFS in those patients.
Just curious, right now, if you had equal access to all 4 of these agents, we'll talk both about FL as well as diffuse large B-cell, and there was no difference economically or any other way, just easy access to any of the four, would you have any preference of what you might use first, both in FL and diffuse large B cell? Or is it kind of like letrozole and anastrozole in breast cancer, pretty hard to tell the difference?
Maybe for efficacy, it's hard to tell, but there are differences in the treatment schedules and the ease of administration. And I think that's where it becomes, when you're taking those factors into account, easier to identify a preference. So for follicular lymphoma, the biology of that disease, it's typically a slower growing lymphoma. Patients typically don't require urgent therapy. I really do favor mosunetuzumab for those patients. It can be administered outpatient. The rates of CRS have been quite low, and it's a time-limited therapy, which patients also really like. We're still awaiting more data to see how people do if they do have a subsequent progression and need to be retreated. So I think those data will be really helpful when available. But for now, if I had to choose a therapy for a patient with FL, mosunetuzumab seems hard to beat. If I'm worried someone may have a transformation, then I may be going to reach for epcoritamab, because I know that it's approved for both aggressive lymphoma and follicular lymphoma. And we've seen data on mosunetuzumab as a single agent in diffuse large B-cell lymphoma. And the efficacy, although again hard to compare across studies, does seem a little bit lower than the other drugs in the aggressive histologies with mosunetuzumab alone. And so if I have a biopsy that shows follicular lymphoma, but there are some sites that have me worried that on the PET scan with high SUVs, that might be someone that I'll choose epcoritamab for. For diffuse large B-cell lymphoma, it comes down to the treatment schedule, and glofitamab's time limited, 12 cycles. And so I think a lot of people prefer that strategy as compared to the continuous treatment with epcoritamab. But maybe, again, hard to compare. There were, at least numerically, some slightly higher rates of grade 3 CRS with glofitamab. So maybe if someone was frailer, I might be a little more hesitant there. But that's just a feeling, not proven.
So again, assuming you had equal access to odronextamab, for example, in that situation with FL that you described, where you would maybe favor EBCO because you're concerned about the possibility of transformation, where would odronextamab, would that be an equivalent choice or maybe not as ideal?
It could be similar. The split dosing is a little bit more cumbersome with the odronextamab as compared to epcoritamab. So that might sway me away from the use of odronextamab there. But so if all were available, I probably would choose epcoritamab. But it is similarly one that seems to have activity across the different subtypes.
What do we know about using a different bispecific after a prior bispecific?
That I haven't done because these are all targeting CD20. So if somebody failed a bispecific that was targeting CD20, I wouldn't reach for another CD20 targeted bispecific. But there are many other drugs that are in development that are looking at unique targets. So those are earlier in the pipeline across different companies, but I think I would imagine they could still be active. We've seen studies now looking at efficacy of bispecifics after CAR T that show that bispecifics can still work even if you've had a T cell directed therapy. And similarly, there was a paper recently that looked at patients responding to CAR T after bispecifics. So I think we can still use these types of T cell approaches, but we just probably need a new target.
So, just a couple of thoughts about the issue of bispecifics in a community general medical oncology setting. And, in the past, a lot of, immunotherapies, particularly CAR T, have gone to tertiary centers. And then there's also the strategy that I've seen used a lot in bispecifics and other treatments where the patient starts out at a tertiary center and then returns to the community. But what are the situations right now where from your perspective, you could see a community-based general medical oncologist starting a bispecific? And also, is it necessary to carry tocilizumab in the clinic in order to do this?
Yeah, that is the goal to be able to have bispecific antibodies be accessible to patients across different settings. CAR T cell, we know, is a really great option for patients, but we still don't see the majority of patients being treated with this drug that we know has an OS benefit in the second line. And so, with this drug, which is off the shelf, we'd really love to be able to see people be able to access it, even if they can't come to a major city. Or a major oncology practice. But the risk of CRS does still is still scary because although the majority of patients will have grade 1 CRS, which is easy to manage, if you do run into that patient who has more severe cytokine release syndrome, it can be scary and they do need intensive support, including ICU and tocilizumab. So I was part of an effort with multiple other providers across the US and globally who were involved in clinical trials with bispecifics, and we put together consensus recommendations on how to manage the toxicities of bispecific antibodies that hopefully people in the community can reference with a lot of detail on what to do if patients do run into trouble. And having access to tocilizumab is really a standard. They should have at least a plan of a place that's nearby to send a patient if they were developing CRS that has at least 2 doses, typically is sort of what's in the recommendations available in some plan, whether that has to be their oncology practice or a collaborating emergency room or hospital, it should be available. But I do envision a future where the community will feel more comfortable using these drugs because we've seen it with other oncology drugs that have been challenging to use. I've seen it in lymphoma and CLL. People used to come to us for the ramp up for venetoclax. Now they no longer do. We've seen it with checkpoint inhibitors where, there were lots of toxicities initially that were hard to manage. And now people in the community, I'm sure, give more immunotherapy than many of us at Dana-Farber. So I think that we'll all get there, but I think it's just going to take that comfort. There are some community sites that I've collaborated with who have started to participate in some of the trials, and they have the comfort now and are able to use these. The other thing is we're learning ways to mitigate risk of CRS, and I think as we finesse that, we may find ways to decrease the incidence, whether that's using chemotherapy with bispecific antibody or having patients with steroids at home. Those kind of things will be helpful.
Yeah, I always flash back to one of the first times we presented HMA venetoclax for AML to a community oncology group, and everybody was like, "Whoa, we're not going to be doing that." And of course, now they do it like every day, it seems like. So yeah, quick uptake there. Can you comment about the issue of infections with bispecifics, and particularly from the point of view of, again, a doc in practice and a clinic in practice? What are some of the things to think about? How you strategize in terms of preemptive anti-infectives, vaccinations, and maybe more of a global view of how much of an issue this is.
Yeah, I think it's a major issue with the bispecific antibodies, and I think we're learning more that this is something we have to be paying attention to. We know that lymphoma patients can be at risk of infections in general. These are in the patients getting bispecifics right now are heavily pretreated. They're approved for the third line and beyond, and they're a B cell depleting therapy. We know that even patients on maintenance rituximab can be at risk of recurrent infections. So we put in the consensus recommendations that patients should be on prophylaxis against PCP and VZV through the duration of the treatment, and probably with some tail of what exact amount of time after completing the therapy is sort of not clear, but I probably would continue it a few months after completion of the bispecific antibody. And then it's also important to be monitoring like IgG levels. I've had a couple patients, and one of the cases I brought up is a patient who had recurrent infections and has continued on IVIG replacement therapy and is doing better now. But we saw a lot of COVID-19 that during the time of these trials, and it's always hard to know, was that just because it was so prevalent in the community, or is it that our patients in particular are specifically vulnerable to those types of infections? And I think we see that with bispecifics.
Yeah, I was mentioning we had Jennifer Brown on a webinar the other day. We were talking about the Amplified trial there, and there were a lot of COVID deaths there, particularly in the arm that had the AVO with obinutuzumab, the anti-CD20. What about the issue of CAR T versus bispecifics in terms of what comes first? Also, currently, what's the bar in terms of functional status to go for CAR T? And how you think through the issue in FL versus diffuse large B cell?
Yeah, this is a common question that keeps coming up. And I think this probably depends on the disease subtype. For follicular lymphoma, I think there's more of a comfort in going straight to a bispecific antibody as the first choice. Like I mentioned before, there's usually less urgency in getting someone on treatment, and there may not be such a rush to get the patient to CAR T cell, which can be associated with more toxicity. And so if you start with a bispecific and happen to get a really prolonged duration of response or CR, that's really great. And you can prolong CAR T, and maybe we'll have something even better by the time the patient needs their next therapy. And so for follicular lymphoma, I would lean towards using a bispecific first, although it's still a discussion to have with the patient. There may be someone who logistically it's much easier to have one therapy and be done. We have Lysocell now for follicular lymphoma, which has a pretty favorable safety profile. So it's something I would think about. And for a particular person, I would discuss it if they were younger, for example. But for an older patient who's okay coming in for continued treatment, I would reach to the bispecifics. For large cell lymphoma, it's a little bit of a different story just because of the data that we have with CAR T has been showing in a subset of patients prolonged remissions now and potentially a cure. And so where in this disease, if you miss your opportunity to cure somebody earlier, it can be challenging to ever get a response again. And where we have data of CAR T showing an overall survival advantage in the second line, I still would favor using CAR as my first treatment of a patient with refractory or early relapse of disease. We are using CAR T cell now, even in older patients. I just gave CAR to a patient who was 83 last week, and they did great. They've done great so far. It's pretty early, but bispecifics probably are still easier to tolerate. So if you have somebody that you're worried about using CAR T, that's where I would reach for a bispecific antibody. And we do see a lot of elderly and frail patients. And we see patients who also don't want to go in the hospital for a week for CAR T cell, or they don't want to have, they don't necessarily have the caregiver support required for CAR T. There's just more logistical considerations with that therapy that it may be easier for them to get a bispecific antibody. So that's sort of how I would think about it now. And I'm sure things will continue to evolve as we see longer follow-up, retreatment data, and other combination studies reading out, which might change the whole order of things. So I think there's a lot that still could change.
All right, well, let's get into your cases, starting out with your first case of a 68-year-old man. Can you talk about what happened with him?
Yeah, this one is a really bread and butter case to start with. This is a gentleman who had a history of esophageal cancer he had been in remission for many years and doing well, but continued to have annual surveillance imaging with his GI oncologist. And on one of those scans, he was found to have a bulky abdominal mass measuring greater than 7 centimeters. So, given his history, of course, it was presumed to be esophageal cancer, but on biopsy showed grade 1 to 2 follicular lymphoma. He had a PET scan. It didn't seem like there was any evidence of transformation, but given the size, he was a candidate for initiating therapy. So he started with bendamustine and rituximab and achieved a CR. He tolerated that therapy well, but just under 2 years later, he was found to have recurrent disease in the abdomen and as well as some other lymph node sites. And so at that point, he was treated with lenalidomide, with rituximab, and had a mixed response to that after a few months of therapy, and then transitioned to mosunetuzumab, which we mentioned before is approved for third line and beyond. He really had an easy course with that therapy. He achieved a CR after cycle 3. And so for patients who achieve a CR after 8 cycles can discontinue therapy. So he was able to discontinue therapy and has remained in a complete remission. So this is sort of just a kind of pretty standard third line FL patient who has done well with a bispecific. It was all given in the outpatient setting. And he actually didn't have CRS.
Anything you want to say about his images?
No, just added to just kind of show the kind of impressive response that he had. This was pretty early, and this is what we can see with the bispecific antibodies. Many people are showing responses even on their first or second response assessments.
So you mentioned earlier on that a couple of these agents, EBCO and odronextamab, are used kind of indefinitely, or I guess until progression. For practical purposes, is that actually what happens, or do people, if they get stable or they have a CR, do you think it's rational to hold off on treatment?
I think that many of the patients who are achieving a CR are wanting to discontinue. So it's definitely a discussion. I think the third case will address that issue that came up with a patient. But the few that I have had stop early have had issues with infection. And then they were having such a good response that they decided to stop and have been able to stay in remission. And so I wonder if we'll hopefully maybe use new tools, maybe tools like MRD, or maybe there'll be studies of stopping patients with a CR that we can then follow, or even patients from the trials who elected to discontinue therapy early. Maybe we'll gain some confidence that that's a reasonable approach, because it is tough for patients to remain on therapy indefinitely if they've had a great response.
So I can't recall who actually made this comment. I think they were presenting a case of where they gave the patient corticosteroids to take to have at home, and said, "Call me if you have a fever," and they manage over the phone and tell them to take the, oral corticosteroids. Is that something you ever do?
I do. I think it's helpful for patients to have a dose of dexamethasone at home, but it's really important for them to make sure that they call so that you're aware of it. If someone does have a fever, I think it is typically good to see them, or at least check in with them in the morning. But if they call and it's late at night, and especially if they have the ability to check their vitals at home, sometimes patients will get a home blood pressure cuff and they can tell you that everything is stable. I just have a fever. And that's not someone that I want to be awake all night sitting in the emergency room. And so then our team can check in with them the next day and ward off a visit to the emergency room, which is the goal. So I think it is good to have a dose at home.
So I always love cases that start out 89-year-old. What happened with the 89-year-old man?
Well, this one is a little bit of a sad case, but it had a few teaching points. But he was a very fit 89-year-old who I think there's just a couple kind of teaching points to mention. And so this is a patient who was a patient of mine who had follicular lymphoma, and he didn't require therapy initially. He was observed for a few years, but then later presented with abdominal pain. Imaging showed a pretty significant change in the size of his lymphadenopathy, and PET scan also showed that the mass now was very FDG avid. It was the SUVs in the 20s. We got a biopsy, and it looked like he now had transformation to a high-grade B-cell lymphoma with MYC and BCL2 rearrangements, so a double-hit lymphoma, which we can sometimes see in the context of a transformation when people gain a MYC translocation. And so this patient received mini R-CHOP. He did really well with chemo, but his disease was very difficult to treat. He had a mixed response. We had talked about maybe CAR T, but I think at that point he wasn't. He was sort of one of the older patients we were alluding to previously, who kind of didn't really want to do CAR T cell therapy. I wanted to give him epcoritamab in the second line, but it's approved in the third line. So we gave a dose of Pola-R. It didn't work. And then he proceeded with epcoritamab. The reason I wanted to mention this case is I've had a lot of questions that have come up. This was someone who was rapidly progressing even during the ramp up. And so what do we do when we have a patient who has really aggressive disease and we're giving this really slow ramp up? And there's been a couple cases of patients even who've been in the hospital who have received more rapid ramp ups. This is off label. This is not something that, I would recommend, but sometimes you may have to do it. And so I thought this was an example of just a real life case that we sometimes run into when we can't use the drug in the kind of exact way it's intended to. And so there was an abstract at ASH this year looking at patients who were failing CAR T and starting bispecifics. And this was a study from the Lisa group, and they did a more rapid ramp up with glofitamab. It was on day 1 and 3 with the first 2 doses instead of going a week, and it seemed to be safe. So I think that's the advice I would give to people: at least follow something that has been presented from a clinical trial if you're ever in that situation of needing to do that. In his case, I pressed on with the scheduled ramp up as scheduled and I didn't give up too quickly because I knew he was getting a subtherapeutic dose. So if they're stable, the other thing to do is to just give it more time. And so the other thing with epcoritamab is that it's standard to give the 4 days of steroids to mitigate the risk of CRS. It has a more aggressive prophylactic strategy for CRS with the 4 days. And for this patient, it was actually helpful because it helped control his disease while he was going through the step-up period. Ultimately, this patient did have progression, but we were able to get him through the ramp up, and he did quite well. The other reason I wanted to bring up this case is because he was older. He was almost 90. I did decide to admit him for his first dose, and that's not recommended per the label, but I just like to highlight to other providers that you don't have to follow exactly what's in the label if you're worried about a patient. If you want to give a drug, but they're on the fence, you can always just make a modification to do it in a safer way. So for this patient, he did fine. I admitted him 1 extra night, and I felt better about dosing him under closer supervision.
Anything you want to say about the images?
You can just kind of see here that there was, even over a relatively short period of time, rapid progression. This patient had double hit lymphoma. In the epcoritamab study, they did include over 10% of patients with double hit lymphoma, and they did report a few responses. I don't think that was the same with the other bispecific antibodies, which is why I was leaning towards epcoritamab for this patient. Also, given that he was older, I thought it may be better tolerated. But yeah, this case is not to highlight that epcoritamab is worse than any of the others. It's just I think this patient had really difficult to treat disease.
All right. How about the 71-year-old woman?
So this was a patient who was treated on the ELM-1 study. We had that study open for many years, and this was the follicular lymphoma expansion cohort. ELM-1 was their phase 1 study of odronextamab. And so she initially presented with lymphadenopathy. She had involvement of the spleen and bones. She was symptomatic and initially got treated with BR. So she was another patient who had this early relapse of follicular lymphoma, what we would consider POD24, progression of disease within 24 months. We know that those patients are more difficult to treat and have an inferior prognosis as to patients with later relapses. She was ultimately able to go on the ELM-1 study, and she did experience grade 1 CRS with the step-up dosing, but did fine. And she had a very early CR. So this was the example that I wanted to give of a patient on continuous therapy who wasn't able to stay on therapy. She was treated for approximately 1 year, and she had issues with recurrent pneumonia. So this is just the dramatic response. This was her 3-month PET. So she had recurrent issues with pneumonia. She was treated with antibiotics, but then would be symptomatic again like a month later. She had hypogammaglobulinemia and got started on IVIG. And ultimately, it just, especially given that she was in a CR, it didn't make sense to continue her on odronextamab. So we discontinued therapy, and she's actually been in remission for over 5 years. So this is someone who relapsed after BR in less than 2 years. So it just shows that these drugs are incredibly effective, but it also shows the risks of them in terms of risk for infection. So she's still getting monthly IVIG. Could she at some point taper off? Potentially, but she's been doing really well. So she's stayed on repletion.
Really an amazing case. I'm curious what your experience clinically has been with odronextamab, having used it on trial, and indirectly, what's your experience both with the tolerability and efficacy compared to the other bispecifics?
Yeah, we've seen some cases like this. I feel like the patients, most of them have done well in terms of efficacy with follicular lymphoma. Diffuse large B-cell lymphoma, it's more of a mixed bag, and that's consistent with what we saw in the clinical trial. We were one of the top accruers for the post-CAR T-cell cohort, and I would say the overall response rate of about 50% was consistent with what we saw. People, if they didn't respond, usually progressed very early. And then otherwise, the patients seem to do well. Early on in the study, we didn't have any long-term data for how patients were going to do once they achieved a CR. And so I sent a couple patients straight to allogeneic stem cell transplant once they achieved a CR. I have one of my patients from this trial who had double hit lymphoma, failed CAR T, and then had achieved a CR. And he's been in remission after an allo transplant for 5 years. So I still don't know whether you should do a transplant or not. I think that's really debatable for diffuse large B-cell lymphoma. We are seeing that the patients at that 3-year follow-up, if they achieve a CR, the curves are flattening out, but I don't know if we will still see relapses later. So it's something I think about for younger patients. But for older patients, I'm not necessarily jumping to allo transplant, but it's something I wonder about. I think most people at other sites don't do it, but and at Dana-Farber, we talk about it.
You know, I'm sure this lady appreciates, if she understands the fact that she didn't have an allo transplant, is doing great more than 5 years later. So odronextamab is approved for FL and diffuse large B-cell in Europe?
I believe so.
And why is it not approved in the United States? I mean, it's always an issue when you have multiple agents in the same class, but why is it not approved in the United States?
I think it just had to do with the timing, unfortunately, for the company that has odronextamab, because the data do all look very similar in terms of efficacy for the different subtypes of lymphoma. But when this one came to be reviewed, we already had availability of the other agents. And so I believe the FDA wanted to see data from the randomized trials before granting approval. Just given that the urgency to have another bispecific was not as obvious. That's my understanding, but I don't think it's because it doesn't work as well.
Yeah, I mean, again, we see this in oncology all the time. The analogy I like to make is actually in non-small cell lung cancer, where pembrolizumab is used in general all the time, but it just so happened that a trial in locally advanced disease, not in metastatic disease, durvalumab, another PD-1 inhibitor, had better outcomes, and that was what became standard, and so everybody used that. And I guess the issue when you have multiple agents that look very similar, we were talking about oral SERDs and breast cancer last night, same issue. You know, you have the issue of, oh, well, is it worth having another alternative, even if it doesn't look that great? But the other issue is, you know, once it gets approved and then you see it pop up in another setting. And I guess the obvious issue here is moving it up, moving bispecific in general up earlier, particularly to the first line. And you mentioned all the, you know, trials going on right now. It would seem that that is such a obvious and likely thought to have. What are some of the trials going on right now in earlier stage disease, even second line, but particularly first line? And can you envision a scenario in the next few years where they're going to be incorporated into first line therapy, both of FL and diffuse large B cell?
I do. I think that's where the bispecific kind of treatment is heading. So in follicular lymphoma, we've seen data of mosunetuzumab in the frontline subcutaneous dosing, which is different than what's approved. Very, very kind of early favorable results seen at ASH with that. We have two studies open at our center looking at epcoritamab and glofitamab in the frontline for follicular lymphoma that have been very popular. It's just very early on those studies. And then we're also seeing combinations like bispecifics with lenalidomide, for example. So I think that for patients who don't want to have chemo as their initial therapy, those are very appealing options. And the data so far in terms of outcomes seem very good. It's just very early in small studies. For diffuse large B-cell lymphoma, it seems like there may be a role for bispecifics in combination with chemotherapy. So we've seen data of bispecific EPCO and GLOFIT in combination with R-CHOP. There's a big randomized study going on right now comparing Pola-R-CHP to GLOFIT Pola-R-CHP. So that everyone is very excited to see the outcome of that study. And then we participated in a similar study that will be hopefully presenting at one of the next meetings, looking at GLOFIT with Pola-R-CHP with just a slight change in the treatment schedule to try to decrease risk of CRS. So that's an appealing option. We've also seen some trials that are looking at checking MRD after a few rounds of treatment and using MRD or early response assessment to guide whether someone is escalated to add in a bispecific. And those ideas are also interesting as well. Maybe not everybody needs this, but maybe we can pick out the patients that it's worth adding in that extra risk of toxicity. And the goal is to cure these patients with diffuse large B-cell lymphoma with their initial therapy. We don't want them to need CAR T or some, other therapy. The outcomes, even though patients can still be cured with CAR T, they're not great. So if we can, even though the outcomes are already good, if we can make them better in the front line, that's the goal for DLBCL, and hopefully bispecifics can do that.
All right, let's finish out with your last case, this 82-year-old man. What happened with him?
So this is a case of glofitamab. I guess I chose all older patients today, but that probably speaks to the patients that we see with lymphoma. But he had a history of transformed marginal zone lymphoma. Initially was treated with single agent rituximab for that disease. It was splenic marginal zone lymphoma and did well. And his end of treatment PET scan show uptake within the bowel. And that area was biopsied and suggestive of diffuse large B-cell lymphoma. So transitioned him to R-CHOP. This was a while ago before we had other options. He got R-CHOP, had refractory disease, then got R-GEMOX, refractory disease, was treated with CAR-T, and had a complete response. However, about 2 years later after CAR-T, this is a little rare because most of the time with CAR-T, we see earlier relapses, but he did have a recurrent disease in the bone marrow and had a biopsy that showed recurrent DLBCL. And so, again, this was a while ago, got Pola-BR, did achieve a response, but like what we see typically with that regimen, he ultimately relapsed and has been on glofitamab. He is finishing his therapy now and has achieved a complete response. So this is a patient with tricky to treat disease, lots of relapses. I think this kind of speaks to where we are in the field of diffuse large B-cell lymphoma. We have so many options now for patients. So even though his course has traversed many years, he's gone through many different lines of therapy, we have a new option for him now, which is the bispecific antibody, and he has achieved a CR. So he, just to remind you, this is a fixed duration therapy with glofitamab, and he's coming up on the end of cycle 12. So hopefully he'll be able to discontinue therapy and stay in remission or have some duration of complete response, which is meaningful. So that was just sort of another example of DLBCL.
Anything you want to say about the images, and also how did he tolerate treatment and his infectious complications?
He hasn't had infectious complications. I think he may have had a fever with the first dose. Right now with glofitamab, it is still recommended that patients be admitted for their initial dose. They get the dose of obinutuzumab, and then the highest rates of CRS are seen with the first dose. That's a little different compared to epcoritamab, where you see it most commonly with the third dose. And so he had a fever, but he was being observed inpatient, and he was okay. He didn't have to deal with anything at home. And he hasn't run into issues with infection, but of course we have him on prophylaxis and are monitoring him.
Any evidence of neurologic issues like ICANS with bispecifics?
That's an important toxicity to be aware of, and especially knowing that we can see that with other T-cell therapies. The rates of ICANS are very low with bispecific antibodies. I haven't seen it with any of my patients. It's been reported in trials, so it's very rare when it's reported, but so people should be aware that it can happen, but it's also important to know that it's not the same risk that we have with CAR-T. We actually don't say that people can't drive if they feel well and are otherwise okay, then they can still kind of do the activities they may want to do. It's not the same. But it can occur. If it does occur, we recommend treating it just like you would ICANS for CAR T cell therapy, and then also just knowing that it's rare, be sure to be thinking of alternative causes and not think that this is definitely ICANS, because these are patients who could be at risk of other neurologic issues.
So this has been really a great, very enlightening hour for me to spend with you. I really appreciate it. Anything you want to add to what we talked about today? Any things that we didn't cover? Any questions you get from oncologists about bispecifics we didn't talk about?
I would just say that, like we talked about before, I do envision this being an important drug for patients in the community, and I think that providers are going to find that it's easier to use the bispecific antibody than they think, because now that we've been using it for a while, I already see it at our site where APPs, nurses, and physicians are all more comfortable seeing these patients receive the treatment and dealing with the side effects. And I think that's true of most most oncology drugs, and also just thinking of it as, speaking of all the other providers, thinking of it as a team approach. And if you are going to roll out bispecifics, kind of come up with a plan in advance about who can help, who teaching in advance about the side effects and having clear rules can be really helpful. And then knowing that the providers at the tertiary sites are also happy to help. I'm always happy to get an email or even talk to somebody on the phone if a question comes up. We're happy to see a patient for a second opinion or the ramp up period if needed. So I think that the ultimate goal is to just get the best drugs to patients if they can help them.
This concludes our program. Special thanks to Dr. Crombie, and thank you for listening. This is Dr. Neil Love for Oncology Today, Bispecific Antibodies in the Management of Non-Hodgkin Lymphoma.